Okay.
So the cardiomyopathies are mainly divided into the three types. The dilated cardiomyopathy, which is most common. So this is most common cardiomyopathy, which is dilated. Next is restrictive cardiomyopathy, and last one is hypertrophic cardiomyopathy. So the most common is a dilated cardiomyopathy, and the dilated cardiomyopathy causes are divided into two types, right? Ischemic causes and non-ischemic causes. So the most common cause of the dilated cardiomyopathy is ischemic causes after the myocardial infarction. Ischemic causes simply mean the myocardial infarction. Okay. So the dilated cardiomyopathy lead to systolic heart failure, right?
Yes.
While the restrictive and hypertrophic cardiomyopathy lead to diastolic
So,
heart
heart failure.
failure. So
Yes.
diastolic heart failure means impair
Contraction.
ventricular filling. Impair ventricular filling.
Yes.
So the systolic heart failure means decreased contractility. Okay, before going to detail in the different types of the cardiomyopathy, first we'll discuss about the myocyte hypertrophy, right? The myocyte hypertrophy is divided into two types, eccentric hypertrophy and concentric hypertrophy. So these hypertrophy related mechanism is again a very high yield stuff, right? On
Okay.
exam you got a winnet and they ask about the mechanism behind this pathology. Okay, so the eccentric hypertrophy simply means the sarcomere added in added in
Series.
series, right? While
Yes.
in concentric hypertrophy added in
Parallel.
sarcomere added in parallel, right?
Yes.
So in concentric hypertrophy, this sarcomere added in parallel due to which cause pressure overload, right?
Yes.
Pressure overload. And this is due to eccentric hypertrophy due to the volume overload. So there are a lot of conditions that lead to the volume overload like aortic regurgitation, dilated cardiomyopathies as also lead to the volume overload type of the condition. Pressure overload like aortic stenosis, hypertension, these kind of stuff lead to the concentric hypertrophy. Okay, the concentric hypertrophy lead to decrease the cavity size of the left ventricle. Decrease the cavity size of left ventricle. What about the thickness of the left ventricle? Increase or decrease in concentric hypertrophy?
Increase.
Increase thickness of left ventricle. The opposite take place in eccentric
Dilate.
hypertrophy. So the ventricles are dilated. It means dilated means increase cavity size, right? Increase cavity of left ventricle. So what about the thickness? Thickness, you can say that slightly increase or it remain normal, remain unchanged, right? So the main thing is the cavity. So the cavity size is increase in eccentric hypertrophy, while the cavity size is decrease in concentric hypertrophy. So the condition which lead to the concentric hypertrophy are the chronic hypertension, right?
Yes.
Aortic stenosis and Friedreich ataxia. So these are some high yield causes. And what about the volume overload causes? Eccentric hypertrophy, the mainly the aortic regurgitation, mitral regurgitation, that kind of the etiology lead to the eccentric hypertrophy. Okay. Okay. So the dilated cardiomyopathy, most common cause is ischemia, myocardial infarction. Okay. So non-ischemic causes. Can anybody tell me the what is the familial cause of the dilated cardiomyopathy? Which mutation?
Mutation of the TTN gene.
Okay, TTN gene mutation. So this is a familial causes. Okay. So the familial causes is basically the mutation in TTN gene. So this TTN gene encode the protein titin, right?
Yes.
Sometimes they ask about this kind of thing, protein titin, right?
Yes.
Okay. Can anybody tell me the drugs? Which drugs lead to dilated cardiomyopathy?
Doxorubicin, Doanorubicin,
Okay.
Cocaine, alcohol.
alcohol.
You are absolutely right. So, if you are you are say that doxorubicin is a which class of the drug is
And antineoplastic,
anti-tumor, antibiotic, anti-tumor, anthracycline, right? Anthracycline.
Wait, hold on 1 second, Doc. I think we need if there's noise in your background, you need to mute your mic so that you don't disturb the class.
Okay, thank you. Okay, so the drugs, familial causes, drugs like anti-tumor antibiotics, sometimes they are give as a chemotherapy. They also use in chemotherapy. Anti-tumor antibiotic, Doxorubicin is example. Alcohol, right? So the cocaine.
Yes.
And next is, we already discussed the familial causes due to the mutation of TTN gene.
Yes.
Okay. Which is the most common infection that lead to the dilated cardiomyopathy? Can you name that bug?
Coxsackie B.
Coxsackie B virus. So the infection So the most high yield is the Coxsackie B virus infection, although so many infections, but Coxsackie B virus is a super high yield.
Yes.
Yes, Coxsackie B virus also lead to the myocarditis. You are absolutely right. Coxsackie B virus, right?
Yes.
Okay. So, what are the systemic conditions that lead to dilated cardiomyopathy?
Well, they can be like hemochromatosis,
Okay.
sarcoidosis.
Systemic conditions like hemochromatosis,
Yes. Sarcoidosis.
sarcoidosis, thyrotoxicosis, right? You are absolutely
Yeah.
right. And one more thing is peripartum cardiomyopathy. This is again a high yield. Peripartum cardiomyopathy. So the peripartum cardiomyopathy basically affects the last month of the pregnancy and the 5 months after the delivery. This is the most susceptible time where this peripartum cardiomyopathy risk is highest in this last 1 month, right? And 5 months after the delivery. Okay. How will you treat the peripartum cardiomyopathy? Avoid pregnancy in future, right?
Okay.
Okay. So, dilated cardiomyopathy, which is the best investigation? Which is the best investigation? Echo.
Echo.
Echo. Okay. Echo shows decrease ejection fraction. It also shows the thickness and the size of the cavities as well, right? The investigation is echo. Okay. So dilated cardiomyopathy, the presentation of dilated cardiomyopathy. So patient present with systolic regurgitant murmur. Systolic regurgitant murmur. So S3 is present. So it will lead to systolic heart failure. Systolic heart failure features are present. And okay. So what are the feature of the heart failure? Clinical features of heart failure.
If you have decreased ejection fraction.
Okay. So on the basis of the ejection fraction, you will decide it is a systolic or diastolic. If the ejection fraction is less than, I think the normal range is 55% to 70. If it is less than 55 or 50, it is decreased ejection fraction and it is labeled as systolic heart failure. And if it is normal, then it is the normal ejection fraction. Okay, the treatment of the dilated cardiomyopathy is same as the systolic heart failure. We already discussed the treatment of the uh, systolic heart failure in the heart failure lecture. Okay, so the treatment of the systolic heart failure, can anybody tell me about? ACE,
Yeah, ACE inhibitor, beta
ARBs,
blocker.
ARBs, beta blockers,
diuretics to
Okay.
decrease.
Okay. Beta blocker, Cubitril. I hope spelling is right. ACE, ARB, beta blockers, Cubitril. Can we give the Prinolactone? Yes. It's a Prinolactone. All of these drugs are decrease the mortality, right?
Yes.
Okay. So the same treatment as we already discussed in the heart failure. Okay. What are the next if the patient is not treated from these things? We also give ICD plus biventricular pacemaker. Biventricular pacemaker. Okay, what is a stress-induced cardiomyopathy? Stress,
Stress-induced. Yes. So
stress-
basically, when there's physical, emotional stress, there's a catecholamine surge, and that can lead to vascular spasm, which would then lead to ischemia, and then myocardial dysfunction of the left ventricle.
Okay, the mechanism is still not known. So the stress-induced cardiomyopathy lead to the dilated cardiomyopathy due to catecholamine. You're absolutely right. Catecholamine, and there is apical ballooning of the left ventricle. Stress-induced cardiomyopathy is also known as broken heart syndrome, right? Broken
Yes.
heart, also known as staccato, staccato cardiomyopathy, right?
Yes.
Okay. So the restrictive cardiomyopathy lead to which kind of heart failure? Diastolic.
Yes.
Diastolic heart failure. The diastolic heart failure means impaired
Relaxation.
relaxation or impaired ventricular filling. Okay, so the impaired ventricular filling. So the diastolic heart failure in the restrictive as well hypertrophic cardiomyopathy. What are the high yield causes of the restrictive cardiomyopathy? There is a mnemonic. Please help. So you have to cram this mnemonic. Please help. So P for post radiation. Post radiation. L for Loeffler. Loeffler. Endocarditis. E for endocardial. Endocardial. Fibroelastosis. And A for amyloidosis. Amyloidosis. S for sarcoidosis. And H for hemochromatosis. Okay, so restrictive cardiomyopathy. So what happened on the atrial side? So let's suppose in the restrictive cardiomyopathy, what happened? The filling of these ventricle is impaired. So blood accumulated in these atria. So these atria are enlarged. So sometimes the clinical winners show that biatrial enlargement, right?
Right.
Biatrial enlargement. Take place in restrictive or infiltrative. So restrictive or infiltrative cardiomyopathy are same thing. So the impaired filling of this ventricle, which lead to the accumulation of the blood in these atria and their increased enlargement of these atrial chambers. So on echo, you will find the biatrial enlargement. Right? So what about the ejection fraction in restrictive cardiomyopathy? Remain normal. What about the contractility in
So it should decrease.
contractility also remain normal. So restrictive cardiomyopathy predominantly lead to right heart failure. So how the right heart failure patient present? Right heart failure patient present with increased jugular venous pressure, right?
Yes.
Peripheral edema due to the increased hydrostatic pressure. It also lead to hepatomegaly. Hepatomegaly, right? Okay. So next is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. The hypertrophic cardiomyopathy.
Okay.
So the hypertrophic cardiomyopathy is basically due to the mutation in gene that encoding the sarcomere protein, right? Which protein? Myosin
Second.
binding, myosin binding protein C, right?
Yes.
Myosin binding protein C, and
Beta
another is
myosin.
uh, beta myosin heavy chain. So the beta myosin
Yes.
heavy chain. So you have to remember these proteins in hypertrophic cardiomyopathy. And in dilated cardiomyopathy, is which protein is mutated and which gene is TTN,
Yes. TTN gene for titin protein.
titin protein, right?
Yes.
The hypertrophic cardiomyopathy lead to diastolic heart failure, right?
Yes. Yes.
So diastolic heart failure. Okay. So this is our left ventricle, right ventricle, left atrium, right ventricle. This is mitral valve. This is superior vena cava. Okay. So the hypertrophic cardiomyopathy is basically due to concentric hypertrophy. So the concentric hypertrophy, what it will do, it will reduce the size of the ventricle cavity, right? So size is reduced, right? Ventricle cavity size is reduced. What about the thickness? Thickness is increased. So this is thickness. So this is about the thickness. Thickness is increased and cavity size is decreased. And it lead to diastolic heart failure. So which thing is impaired? So filling is impaired, right? So filling is
Yes.
impaired in hypertrophic cardiomyopathy because of concentric hypertrophy.
Trophy. Yes.
So if the filling is impaired, so what will happen? What will happen if the filling is impaired?
Yes, so that will have a problem with the end diastolic volume
So
being
the blood is
insufficient.
accumulated in atrium, right? So this is blood is accumulated. So it will increase the
Left atrial pressure.
pressure in the left ventricle as well, because the size is decreased, right? And the
Yes.
bulk of the muscle is increased. So the left ventricle and diastolic pressure is also increased, right? And blood is accumulated in the atria as well, right? So the left ventricle and diastolic pressure is also increased. Okay.
Then I have a question, Doc. In that case, so what is happening to the mitral valve?
Okay, so what is happening to the mitral valve? So what is happening in the mitral valve? The mitral valve, so basically it will lead to the mitral regurgitation because of the increased pressure that is generated in this left ventricle. So the increased pressure that is generated in left ventricle, it will shift this mitral valve, particularly the interior leaflet, toward the aortic valve, right? And in this way, it will lead to the mitral regurgitation, right? So it will increase the risk of mitral regurgitation. So impaired filling of the left ventricle, blood is accumulated in the atria. So increased blood in the atria may lead to the enlargement of the left atria. So left atrial enlargement increase the risk of which arrhythmia?
Atrial fibrillation.
Atrial fibrillation, right? So in this way, it will lead to the increased risk of atrial fibrillation as well. So it also increases the risk of VT, ventricle tachycardia. I don't know the mechanism about how it will lead to the ventricle tachycardia, but it increases the risk of ventricle tachycardia as well as atrial fibrillation, right?
Right.
Okay. So one more thing. If the preload is more, right? So it will lead to the increase and diastolic volume, and it will relieve the obstruction of the hypertrophic cardiomyopathy. Keep this principle in the mind. Simple, straightforward. Increase preload, decrease obstruction. Decrease obstruction in hypertrophic cardiomyopathy. So decrease obstruction takes place in this hypertrophic cardiomyopathy if the preload is increased. What about if the preload is decreased? Obstruction in the hypertrophic cardiomyopathy increase or decrease?
Wait, can you repeat the question, please?
The general principle.
Decrease.
General principle, right? So what happened in the hypertrophic cardiomyopathy? The cavity size is decreased, left ventricle cavity size, right?
Yes.
So the cavity size is decreased, right? So
Yes.
to keep this cavity mean patent or open, you need preload, right?
Yes.
If preload is increased, so less obstruction, left ventricle outflow tract obstruction. It also known as LVOT, left ventricle outflow tract obstruction, right?
Okay.
So increase preload, decrease LVOT, decrease preload,
Increase LVOT.
LVOT. This is a high yield point. Increase
Oh,
LVOT. Okay. So why this is high yield? Anything that decrease the preload will increase the murmur, increase the systolic ejection murmur of hypertrophic cardiomyopathy, right?
Say that one more time, please.
Okay. Increase preload mean decrease left ventricle outflow tract obstruction, right? Decrease
Yes.
preload mean
Increase.
increase left ventricle outflow tract obstruction. So anything
Okay.
that lead to the decreased preload
Will increase.
will increase the LVT obstruction, and increase LVT obstruction mean increase the intensity of the systolic ejection murmur. Systolic ejection murmur is basically due to LVOT, left ventricle outflow tract obstruction. Is similar to aortic stenosis murmur, right? So which condition lead to the decreased preload? Valsalva maneuver, right?
Yes.
The Valsalva maneuver. So how the Valsalva maneuver decrease the preload? Because increase intrathoracic pressure, right?
yes.
Increase intrathoracic
Pressure.
pressure. So anything that decrease the preload will increase the intensity of the systolic ejection murmur, or anything that increase the preload. Which thing increase the preload? Can anybody tell me the condition? So question give you these kind of the maneuver.
Okay. So
Squatting, raising the leg,
squatting.
squatting,
Yes.
raising the leg, these kind of the maneuver will
Hand grip.
decrease. Hand grip. These kind of the maneuver will decrease the intensity of systolic ejection murmur, because they will decrease the left ventricle outflow tract obstruction, right?
Right.
Yes.
Okay. So keep this principle in your mind. Keep this principle in your mind. Okay. So what pathology happening? Hypertrophic cardiomyopathy, decrease ventricular filling. So the decreased ventricular filling, So how will you improve the ventricular filling? By giving which drugs? Beta blockers and calcium channel blockers. How they increase the ventricle filling? By decreasing the heart rate.
Contraction.
Decreasing the heart rate. So decrease heart rate, increase time for ventricular filling, right?
Okay.
If heart rate is increased, let's suppose if heart rate is increased, so diastole is shortened, right?
Yes.
So that's why we will decrease the heart rate and improving the ventricular filling by giving the drug like beta blocker and the calcium channel blocker. And we should avoid the drug that decrease the preload. Which drug decrease the preload?
Nitroglycerin.
Okay. Vasodilator, nitroglycine. You are right. Okay. So it will increase. So I am talking about the treatment of the hypertrophic cardiomyopathy. So it will increase the risk of VT and atrial fibrillation. So you can treat this patient for ICD as well. ICD. Okay. And you can give treat surgery is also option. LVT, for LVT, surgery is option. LVT. Different kind of the surgeries are available, like myomectomy, septal ablation, these kind of, right? Okay.
Yes.
Okay. So the we have two conditions. This is question for you. Dilated cardiomyopathy and hypertrophic cardiomyopathy. What happened to the ejection fraction in dilated cardiomyopathy?
Decrease.
Or decrease.
So it will, ejection fraction will decrease.
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 Okay. So what happened to the left ventricle and diastolic volume?
Increase.
Okay. So this is a high yield. Increase left ventricle and diastolic volume. What about LV, left ventricle and diastolic pressure in dilated cardiomyopathy?
Increased.
It's going to increase.
What about the contractility in dilated cardiomyopathy?
Decrease.
Decrease.
So this is a high yield. This is a high yield. Okay. So what about in hypertrophic cardiomyopathy? Ejection fraction.
Yeah.
Maintained. Normal.
Normal.
Normal. What about left ventricle and diastolic volume?
Decrease.
Decrease.
This is a very confusing question. So this is the very end. This is the high yield stuff. So it is remain normal. So it may be decreased, but USMLE love to ask remain normal, right? Because left ventricle and diastolic volume remain unchanged in hypertrophic cardiomyopathy, although you expect that it will decrease, right? But just make some sort of the because this is a high yield. I don't know why, but USMLE love to ask this kind of thing. So left ventricle and diastolic volume remain unchanged because the pressure is increased. So the pressure is increased, only the left ventricle and diastolic pressure is increased, right? What about the contractility?
Contractility will decrease, right?
In hypertrophic cardiomyopathy.
In hyper.
Remain unchanged.
Remain unchanged, yeah.
Okay, so these are high yield. These kind of the arrow you will confusing about these kind of stuff. So these are the high yield. Okay, so you may also these kind of the picture in your Q-Banks question, right?
Yes.
So this is the example of which
Hypertrophic.
hypertrophic. So Q-Banks love to ask mechanism. So it is concentric, right?
Yes.
And this is
Eccentric.
eccentric. And the condition?
Dilated.
Dilated. And you know the detailed condition in the dilated cardiomyopathy. The picture and these arrows again, the high yield, right?
Correct.
Fizan, you didn't say about contractility in dilated cardio in hypertrophic cardiomyopathy. What happened to the contractility? Increased or remained the same?
Generally speaking, remain unchanged. The only thing that will change in hypertrophic cardiomyopathy is left ventricle and diastolic pressure, right?
Right.
Okay, I'm changing the slide.
So,
just give me a 1 minute. Okay, is my screen is again visible or not?
no, not yet.
Okay, so these are my notes that I made for you. So these are some high yield stuff related to the cardiomyopathy. I hope my screen is visible.
Yes.
Yes.
Okay, so these are the dilated cardiomyopathy causes are divided into the two types: dilated, ischemic. Most common cause of the dilated cardiomyopathy, like MI. Non-ischemic dilated cardiomyopathy, there are multiple causes: idiopathic, viral, Coxsackie-B virus, peripartum, we already did chemotherapy, doxorubicin and anthracyclines, these kind of the anti-tumor antibiotics, familial, TTN gene mutation, tachycardia mediated dilated cardiomyopathy, particularly the atrial fibrillation, increase the risk of and the stress cardiomyopathy. It's look like the anterior MI. Look like the anterior MI. This is again high yield stuff. You may find the ST segment elevation in interior lead of ECG, right? And in dilated cardiomyopathy, in ischemic, there is focal hypokinesis. And in case of non-ischemic dilated cardiomyopathy, global hypokinesis, right? Okay. Just giving me a 1 minute. The restrictive cardiomyopathy, these are again the high yield points. Restrictive cardiomyopathy lead to the diastolic heart failure, the biatrial enlargement with normal left ventricle function and size. So the diuretics only for the symptomatic relief for the restrictive cardiomyopathy. So the diastolic heart failure, the treatment of the diastolic heart failure is only the diuretics, which give only the symptomatic relief, right? And you have to identify the cause and treat that cause. And prominent right heart failure in restrictive cardiomyopathy, Kussmaul sign, and you have to cramp the mnemonic. Please help. Okay. So the hypertrophic cardiomyopathy. So it will lead to the concentric hypertrophy, normal ejection fraction with increased wall thickness, autosomal dominant with variable expression. This is again a high yield, super high yield, variable expression. So variable expression, so some patients may remain asymptomatic. Some has the severe, very severe increased severity. So the variable expression, most common cause of sudden cardiac death in young athletes. Present with mitral regurgitation, syncope, and sudden cardiac death. Systolic ejection murmur is basically due to the LVOT, left ventricle outflow tract obstruction. Other feature, holosystolic murmur of the mitral regurgitation, S4 sound, paradoxical splitting of S2. Right? How will you differentiate it? Systolic ejection murmur from aortic stenosis. We already discussed about the systolic ejection murmur of the hypertrophic cardiomyopathy will increase with decreased preload, right? Anything that will decrease the preload, it will increase the systolic ejection murmur of the hypertrophic cardiomyopathy. Systolic ejection murmur is basically due to the left ventricle outflow tract obstruction. So, but in aortic stenosis, this does not take place, right? So again, the associations. So can anybody tell me the which association with hypertrophic cardiomyopathy are high yield? So the maternal diabetes increase the risk of hypertrophic cardiomyopathy in infants, right? We already know that the Friedreich ataxia. So this hypertrophic cardiomyopathy that takes place in the infant is a transient hypertrophic cardiomyopathy. Transient hypertrophic cardiomyopathy. What are the difference between the hypertrophic cardiomyopathy and athlete heart? So these are some high yield points that I noted for you. Okay. Okay, what are the difference between hypertrophic cardiomyopathy and athlete heart? So in hypertrophic cardiomyopathy, the left atrial size is increased. While in case of the athlete's heart, the left atrial size will remain normal. While in case of hypertrophic cardiomyopathy, left ventricle cavity size will decrease. While in case of the athlete's heart, the left cavity size slightly increase. Diastolic function of the left ventricle impaired, while in athlete heart is normal. So the hypertrophic cardiomyopathy is present in the families. So family history is important in hypertrophic cardiomyopathy. What about the left ventricle wall thickness? It is more than 15 millimeter. Okay. So in case of the athlete heart, thickness of the left ventricle wall is less than 15 millimeter. So normal is 10. It is slightly increased. Left ventricle wall thickness slightly increase in athlete heart. Right?
Okay.